Now, this debate is not about who's more beautiful, but really, do we need even more DAs than we already have, right? That's what we're going to talk about. And you see we have a full list of agents. Now, when we entered this, the definition wasn't that clear, so I decided I'll take all the drugs as the ones we have, which are the licensed one, and then I think I also added, and let me just highlight that we even have such a full armamentarium that we're getting rid of the first ones because we don't need them anymore, because we even have more than we want to use because of their sort of limited efficacy and side effect profile. And I also said I'm going to take out the Vox because that's new triplets. I know they're already in the registration process. I'm not going to worry about that, but I'll take the GP on board because it's a dual regimen, and that is already granted priority review, so I thought that is like something we already have there, so I'll leave that in my armamentarium I have to use right now. So if you look at the Easel Guidelines, you will see that we now have easy to take, simple regimens, pangenotypic, different choices for all genotypes. So at least from a guideline perspective, I would say we're well covered and have options for every regimen, for every genotype we have. Looking at the summary of Easel, Jean-Michel already showed his summary. He gives this Easel summaries, and he said, I only have one slide, and that's this, 100%, and what do you really want beyond that? And obviously, I could end my presentation at this point. Now, when you start a debate, you also obviously look in Google, what can you all find for interesting things? And one of the things I found when I Googled Nancy Rowe was an editorial concerning one of her papers, and look what it says, hepatitis C therapy, game over. So Nancy's contributing to the scientific world with publication which suggests that all problems are solved. So what does that say? Well, I decided to sort of touch upon some issues. So I thought she's going to probably say something about, yeah, we need drugs for competition, the prices, so let me tackle that. She's going to tackle our special patient populations left, which may be somewhat different and left behind, the need for shorter treatment durations, need for better tolerated drugs, and I even included, she even mentioned that, I thought it's a pharmacology workshop after all.
I was afraid.
Need for drugs with less drug-drug interactions, and how about treatment of DF failure? So you really see that, although we did not talk to each other about what we were presenting, we covered pretty much the same area, so that's good. So let's look at the price issue. And I think for those of you who attended the Easel conference, there's this wonderful, brave Professor Saïl from Egypt who presented her new prices of DAs in Egypt. And I think it tells you all, right? So if Egypt, which is not a rich country, if we remember, and is undergoing quite some turmoil right now, if you look at the generic price for declatosphere, which is $3, and you look at the generic price for sofosbuvir, which is $25, then you can treat someone for 12 weeks for $28. So how much lower do you think the price really has to get? And in the end, I think we have to appreciate, yes, the prices are different in different scenarios, and it may be difficult to bend the rules. But I think in many countries, in particular in certain European countries, in Brazil, you find very interesting ways how, out of sort of certain price discussions, people end up with a much lower price than in other countries. And that's a function of politicians playing a stronger role in some places than in others. And if you, for example, follow what the Italians or the Portuguese are doing, which are basically saying we can't pay more than a certain sum, but if we pay by prescription volume, then the price goes down. So if you treat more than 40,000 patients in Italy, the price goes down to €3,000. And so suddenly you come up with very attractive prices. So in the end, I think we don't really need new drugs for lowering the prices. What we need is a much stronger formation of stakeholders and politicians to sort of fight and get those prices down. Any special patient populations left? Remember, when the interferon days were there, we saw a lot of differences. We, in particular, saw lower response rates in HIV patients. Well, obviously, they are all responding just as well with way above 96% response rate, so that patient population is over. We addressed the issues of people who were cirrhotic, and I just took one example, and that's the GP combination in cirrhotic patients, 12 weeks, and you see here that indeed through a whole range of genotypes, remember that in this expedition one was cirrhotic patients without genotype 3, everyone else was in there, and you can see really 99% response rate. I mean, where do you see room for further agents down those lines? Looking at The genotype 3 data, you can see that even in the hardest to treat patient groups, so being cirrhotic and treatment experienced, the overall cure rate are high, 96%. There was only one relapse in that particular patient arm. Again, reminding us that with these newer compounds we have now, we actually have improved dramatically those few patient populations which remained more challenging. This is looking at the Elbasvir, Grozepivir, Sofosbuvir combination, also for genotype 3 patients, and you can see here extremely high response rates in the treatment-experienced patients if that regimen is extended. So I think what we're also forgetting is that while we're waiting for combinations, we think of 3 drugs from specific companies, there is at least the option potentially to combine drugs we already have and create 3-drug regimens with the drugs which are already licensed and actually can overcome some of those with DA failure or particular challenging treatment issues. So is there any special patient population truly left behind? Well, HIV co-infected, clearly very high response rates. In the more recent studies with GP, with Grozepivir, Elbasvir, renal insufficiency didn't really seem to be an issue. The cirrhotic studies have now also much higher response rates. Genotype 3, I showed you the data, very high response rate. Inherited blood disorders, transplant patients, you name it. Even in children, one of the final missing gaps has been closed at the last Easel conference with data in the age group of children. And then I thought, wow, what I see here? A presentation from Nancy from 2014 where she gave a course in a forum on hepatitis C, and her summary was, special populations have equal efficacy. So what did I take from that? That really baseline characteristics are becoming irrelevant. And remember what she just told us 30 minutes ago. She said they still matter. Split personality? No, so...
He's a dirty player.
So I think in all fairness, I think we all agree that it's becoming more and more challenging to identify patient populations which are left behind. Need for shorter treatment durations. In the context of HIV patients, there's been nice work from the NIH looking at adherence levels, and it's true. If patients are on a DA therapy after week 8, there is a decrease in adherence, so that may be meaningful. But you saw the 8-week data, which is very reassuring. And in Europe, and particularly in the cost-restrained countries, there is a high use of 8-week, and there's a lot of real-life data confirming that this actually works quite well in the less challenging to treat patient population. Looking at the GP combination, allowing us also a 99% response rate. Oh, sorry, no, this is the AVI regimen for genotype 1b, where you also now, in the lack of, where you also don't need ribavirin and get along with 8 weeks and have a 99% response rate. So for genotype 1b, for the AVI regimen, the ledipasvir, sofosbuvir, for the easy-to-treat genotype 1 patients, I think we have good data, and then obviously we've seen data now also for patients who received 8 versus 12 weeks in the genotype 3 patient population, and again, you can see that 8 weeks did just as well. So now I think we have pretty much for all genotypes also shorter treatment durations available. Need for better tolerated drugs, and I just put in a summary of all the DA trials in co-infected patients, and you can see what has been really outstanding, what has changed clinical practice for those who treat hepatitis C for the last 20 years. Well, there are no discontinuations anymore because of adverse events, or at least they're very, very rare, really underlining the extreme safety and tolerability of these agents. So I think there's really no fruit to get with regard to better tolerability. Need for drugs with less drug-drug interactions. Well, we've heard a lot about drug interactions. We just had in the session before, numerous presentations on, statins and how, but we all learn we can dose adapt. And don't forget, we have a wonderful website, and you want to remain a clinical pharmacologist and have something to do, right? So you don't want to make yourself jobless by saying that you want new drugs with absolutely no drug interactions. You want some drug interactions to keep getting a decent salary. So how about treatment of DA failures? And I think That was very, very smart of Nancy, right? She showed you the Eric Lawitz data and said, see, even if you retreat, there is some hope. But if you have a lot of RAS, look at that, it really goes down to 30%. But what she showed you was a study where people were treated with 24 weeks. But what she didn't show you was retreatment with 24 weeks and adding ribavirin, and that's what happened in the IN4 trial. Now, in the IN4 trial is where we have a certain proportion of African Americans, and that was the target patient population, which failed more frequently than in other studies. And interestingly, when these patients were retreated with 24 weeks plus ribavirin, you can see that indeed 8 of 9 patients achieved SVR, and that was independent of whether they had RAS at baseline, including the Y93H. So telling us that, which has become a common strategy in retreatment, is that actually extending treatment duration and adding ribavirin seems to be a way forward. But on top of that, I think for me, it's at least interestingly, if you think, what do you do in clinical practice when you have someone right now who has failed 2 DA therapies? Well, what you can do in Germany is you can write to the health insurance company and say, would you be willing to allow a retreatment with albuterol, gazeprovir, and sofosbuvir plus ribavirin, because that at least has data, and it's not a licensed indication because it's from 2 different companies, it's not in the label, but you can get an okay, and that's what at least we got for some patients in our center. And you see how excellent the overall response rate, and obviously if 100% respond, then the baseline mutations don't appear to matter at all. So I think we are also having now treatment options in the setting of patients who have prior DA failure. So in summary, I think the question of more drugs, more competition, eventually lower prices. I think prices are really down to $28. It's a question of policy and interaction and combined efforts of all stakeholders in the hepatitis C space. I think that there really are no special patient populations left in the field of hepatitis C. I think there is a need for shorter treatment durations, but that has been addressed with a lot of different regimens now available for 8 weeks. I think the discontinuation rate in trials for adverse events is less than 1%. It really sort of takes away the basis of developing drugs which could be better tolerated. I think there's no need for drugs with less drug-drug reactions. All is solvable with the help of a clinical pharmacologist. And how about treatment of DA failures? 3-drug combinations from 3 drug classes are already available and can be used as a salvage therapy. Thank you very much.